Okay, welcome everyone to the next installment of the Healthcare Innovation Digital Health Virtual Series. My name is Matt Rayner. I am the publisher here at Healthcare Innovation. We are so excited for today's program, the AI Virtual Day. As you can probably guess, today is about all things artificial intelligence and analytics. Whether you're consuming this content live with us here today or watching on demand, thank you for being a part of this program. These sessions are designed to be interactive. Our faculty wants to hear from you. Please do not be shy. To submit a question at any point during today's program, you can utilize the chat functionality within the Zoom platform to submit a question. We'll do our very best to get to all of our audience questions. Throughout today, I will share with you a preview of our Forward Digital Health Virtual Series schedule. I encourage you to learn more about this series, as well as our in-person event series, the Healthcare Innovation and Cybersecurity Forums, by visiting our website, hcinnovationgroup.com. Now, I would love to introduce and welcome onto the virtual stage our editor-in-chief, Mark Haglund, who will be introducing our opening panel discussion. Mark, take it away.
Thank you so much, Matt. Thank you, everyone in our audience, for joining us today or in the future. I love saying that, joining us in the future. Whenever you view this, we so appreciate your participating with us. It is my great honor to welcome three distinguished physicians today: Dr. David Scarda of Intermountain Healthcare, Dr. Sandeep Vijan of Parkview Medical Center in Pueblo, Colorado, and Dr. Ruben Amarasingham of Pieces. What I'm going to do, and our apologies, Dr. Patrick Mcgill was unable to join us because of a technical problem in his area. So what I'm going to do is I'm going to begin by spending a little bit of time with Drs. Vijan and Amarasingham. Then I'll go back and speak with Dr. Scarda, and then we'll basically do a roundtable after I've spoken with all three physicians. So let me begin. I'm going to introduce Dr. Vijan and Dr. Amarasingham. And what Dr. Vijan and his colleagues have done at Parkview Medical Center is quite fascinating, having to do with length of stay. And it was one of those situations where there was a burning platform for change. So Dr. Vijan, why don't you begin? Tell us a little bit about yourself and your organization, and especially the factors that led to your creating, establishing, and developing your length of stay initiative. And after you've done that, then I'll have Dr. Amarasingham say a few words, and then we'll talk about the initiative. So Dr. Vijan, please go ahead.
Thank you, Mark. Thank you for the privilege of the virtual podium here. I'm Sandeep Vijan. I am a general surgeon, first and foremost. I'm the Chief Quality Officer for Parkview Health System in Pueblo, Colorado. We are a nonprofit community hospital, about 260 beds, 42 of those are ICU beds, taking care of a variety of patients throughout southern Colorado, all the way over to Raton, New Mexico. We service an area of roughly 400,000 people, a lot of critical access hospitals, a dearth of primary care, and so we are the first stop for all acute health problems. We have been taking care of the community in Pueblo County and southern Colorado for nearly a century now. We recognize that bed capacity for a hospital is a rate limiting step for growth. And today, as we look at the environment, we turn away several hundred patients referred to us from outlying communities every year. We turn them away because we don't have the bed capacity. To add insult to injury, several years ago, a competing hospital across town decided to downsize their services and focus on some lucrative outpatient healthcare service lines. adding more pressure to Parkview's need to step up to care for the community. At that time, we noted that our length of stay was well north of 5 days, our average acute length of stay. And something had to be done short of building a brand new tower with another new 100 beds to try and take care of more patients. And so that asked us as a leadership team to look holistically at our processes in the hospital, the things that we do to take care of patients, to get them healthy, to get them transitioned into the community, look at any potential inefficiencies there, and put programs together to tackle them. What we realized at the outset of this program was we lacked data. We lacked the ability to mine our electronic medical record to figure out what the barriers were, where the inefficiencies were. And that led us down a journey to artificial intelligence and looking for a vendor partner to help mine our data, because without that, we couldn't build a program.
So you turned to Dr. Amarasingham.
We did. And my predecessor, actually, I can't take full credit for it, but my predecessor turned to Dr. Amarasingham and Pieces Technology several years ago to figure out if we could integrate with our electronic medical record, mine that data, build workflows, and we have had marked success with our program.
Wonderful. Dr. Amarasingham, welcome. Can you just, thank you. Can you just share with us briefly what your core solution related to this does, and how you came together with Dr. Vijan and his colleagues at Parkview to create it for them?
Absolutely. So welcome to, or nice to meet everyone on the call. And I'm a physician and internist. I focus clinically on hospital medicine, and I'm also trained in biomedical informatics. And been very interested in the area of how do technology systems potentially help bring both the joy of medicine back into the workflows, as well as kind of obviously improving care. And that's our mission at Pieces. And we were very excited to work with Parkview, which has tremendous leadership in the form of Dr. Vijan and many other leaders that we've worked with at the institution, which I think is ingredient number one, more important than technology to have the kind of success that they've had. But our role has been to, I think health systems in general, health operations and health facilities are extraordinarily complex institutions. I saw a statistic recently that the average American patient that comes into the US hospital will could interact with more than 100 different individuals during their stay. And there's complex coordination involved with moving a patient through their hospital stay, not to mention all of the critical things like proper diagnostics, establishing a treatment plan, executing on that treatment plan, communicating across that wide body and the patient family, and then leaving out of the hospital. It's one of the most complex the American hospital is one of the most complex institutions. So I think artificial intelligence over time and increasingly can play an important role in coordinating the complex dance that occurs of trying to get a patient better and get out of the hospital safely. And so our small part in that with AI has been to use an AI system, in this case Pieces, to review everything in the record. In particular, we use a technology called natural language processing, which can read doctor's notes, case management notes, social worker notes. The system can also interpret physiologic data and lab data, medication data. It tries to holistically assess what's occurring and then establish these might be barriers for this individual. They could be clinical barriers, they could be non-clinical barriers. We have a big focus on non-clinical barriers, what we call social determinants of health. Then can we surface those, and then can we present them into the line of sight of case managers and others so that they can be aware of these problems, not that they necessarily weren't aware of them before, but when you have so many different individuals involved with the care, you want to have, in a sense, one set of eyes that can say, what may be occurring down the road? Can we start attacking it earlier and closing the white space within the patient journey to to get them out quickly. So that, I think, is one aspect of how AI can be used. And I think it's these kinds of little things over time that I think can continue to improve the care journey, inpatient, outpatient, and elsewhere.
Exactly. Thank you so much, Dr. Amarasingham. Dr. Vijan, so one of the key things that my understanding of our having spoken before is it's the ability to leverage this technology that Dr. Amarasingham just described to intervene early, to identify potential issues much earlier, much farther upstream, as it were, so that the way that you reduce average length of stay is that you intervene earlier so that you're able to actually discharge earlier based on having caught these issues earlier. Is that correct?
That's correct. And so for your audience, I think it may be simpler just to break it down to the old paradigm versus the new paradigm. So the old paradigm as a physician in a hospital is patient comes in, I take care of them medically. By hospital day 4 or 5, they're ready to go home. And I say, okay, discharge this patient home. But there starts problems because is the patient safe to go home? Do they need durable medical equipment? Do they have social support?
Right.
Do they need nursing home placement? And for me as a physician, that's not top of mind. But that's something the nursing leadership of the unit and the case management team need to be focused on to get that patient out of the hospital. Because if we don't tackle these things early, that's an extra 1, 2, 3 days in hospital waiting for these things to get set up. So you can see how the inertia of in-hospital care delivery just is not designed to work together. The case manager who is taking care of 30 patients on a unit, for example, is not empowered to mine the electronic medical record, read every physician's note, every nursing documentation to crystallize the needs of the patient. It's not humanly possible for a single individual. So that's where pieces came in for us. We not only mine our electronic medical record for perceived barriers to discharge, which may be clinical, as Dr. Amarasingham mentioned. It could be the transition of IV to oral medications. It could be the need for oxygen. It could be an identified social determinant of health. They have no family support at home. There is drug abuse in the picture. There are things that the technology can pull from the medical record that hide in what I call dark corners, which is not part of our cognition as we assess a patient every day. And then it crystallizes that information to present to the entire healthcare team daily. So not only now do you have a clear sense of what the barriers are, what specialties need to be involved in this patient's care, what insurance barriers exist, do we need to jump through hoops to get approvals? Exactly. We can start, as you said, moving all of that workflow upstream. And as we move that upstream, that's where the inefficiencies start disappearing. I say this often about length of stay programs. Length of stay reduction, throughput efficiencies are not about magically making the patient better overnight. Around the country, we all have the same kind of antibiotics. We practice a similar kind of medicine, but the opportunities for length of stay reductions come with tackling these operational inefficiencies that are not apparent to the naked eye as we care for patients.
Thank you so much, Doctor. And I just realized that Dr. Mcgill has been able to join us. So let me just ask you one question, and then we'll go to Dr. Mcgill. We'll introduce him. But what have been the biggest lessons learned from this process so far? Especially, I love that you're the chief quality officer and you're a practicing surgeon.
I think the lessons we learned is data is the beginning of your journey. I can't underscore that enough. You start with your data, but what you have to figure out is what pieces of data can you get your arms around and operationalize a program to tackle. And it may not be everything. The data will show you an infinite number of opportunities, but you have to do some introspection as a facility and as a healthcare leadership team to figure out what is the greatest bang for our buck here. What can we truly tackle? And for us, it was putting together a multidisciplinary rounding program. So on a unit at a consistent time every day, the hospitalist, the nurse leadership team, the case management team come together to have that holistic discussion about what are the barriers to discharge and what needs to be done. So I think you have to figure that out. The second lesson we've really learned is culture eats strategy for lunch. If you cannot create buy-in horizontally and vertically across the organization that this is a common goal for us, here are the reasons we want to achieve that goal. If you cannot articulate that organization-wide, you're not going to get the buy-in to get everybody moving in the same direction. So data, workflow, and culture. Those are the three big lessons from any process improvement, specifically length of stay for us.
Thank you so much, Doctor. That was absolutely terrific. Well, I'm delighted Dr. Patrick Mcgill is here. I'm going to have him introduce himself and we'll talk for a few minutes. Then we'll go to Dr. Skarda and then we'll go to our panel. Dr. Mcgill, thank you for joining us. We so appreciate it. Could you introduce yourself to our audience very briefly and then we'll talk from you.
Absolutely. Appreciate you having me here. Patrick Mcgill, I'm the Chief Analytics Officer at Community Health Network in Indianapolis, Indiana, and I'm a family physician still practicing by background. So at Community, we have a unique structure, and in that the Chief Analytics Officer actually oversees all of our data and analytics functions, but also I oversee clinical informatics, nursing informatics, performance improvement, regulatory reporting, and also IT. So I oversee all of our IT operations and functions as well.
Which is wonderful. So tell us, you and I had talked about the fact that you are now leveraging predictive analytics to look at risks of readmission, risks of falls on the inpatient side, and also to drive practice performance improvement on the outpatient side. Can you just briefly summarize a few of the things that you're doing there?
Right. So we, like many other organizations, started with sepsis prediction. I think when we started with predictive models, I think everybody was looking at trying to predict sepsis several years ago when there was a lot of quality improvement work related to sepsis. And we started in the same place. We quickly expanded that into risk for readmission, risk for falls, risk for deterioration. And then we've continued to expand that into our ambulatory settings for risk for no-shows, but then also using some operational improvement models to say where to give some insights where people should change their ambulatory practice, whether it's add more visits here or change how they're practicing to maximize and optimize the ambulatory practices. So it's certainly been an evolution. I wouldn't say that we've, I think with many organizations, this is the predictive models and artificial intelligence is definitely a journey, especially in healthcare. There's a significant change management portion of the work that has to occur. If you work with physicians closely, they want to know what's in the black box, and oftentimes it's complicated and it's difficult to tell them what's in the black box. But I think as long as we can offer up insights, and this is the approach that we've taken, we're not to the point where we're not using the models to tell you what to do. We're just offering it up as another data point to add into your clinical assessment and your clinical evaluation on what, just as you would use a lab value or anything else.
And what has, well, two related questions, I think. One is what have been the biggest challenges of any kind? And the other is, inevitably, I want to ask about changes to physician culture that are needed as one moves forward in this. So what have been the biggest challenges of any kind, and how have you helped to guide your physician colleagues in the cultural changes that get involved in this kind of work?
Yeah, that's a great question. I'll take the first question and then address the second one. I think the biggest challenge is moving people off of their historical processes. And, we've in healthcare, we often are really attached and tied to those old processes. Think about when we have implemented EMRs and other technology and people say, well, hey, paper was working just as fine. Why are we going to this EMR? So I think it's change management 101. It's showing them a different way, showing them a potentially better way, and then as with all change management processes or projects, it's getting that kind of early win and early adoption to have those people turn around and be your evangelists. When we started with the deterioration model in the inpatient setting, we had nurses in the evening and overnight that were just scouring charts manually, and they were looking at 10 to 15 data points in the chart, trying to identify who was going to deteriorate. And when we went to them, and showed them, look, we have a model that'll look at over 100 data points, and it does it in real time automatically. You don't have to look through these charts. They turn around and became the biggest evangelists for a lot of this, and so they became our biggest change management advocates. The second part is, I think, when it comes to physician culture, I think it starts with, as the comments were said earlier, it starts with an understanding of processes. We have, over the last few years, have really preached and talked about when people come to us with data requests. I need a dashboard for this, or give me a report for this. It's really, what problem are you trying to solve? And then let's go get the data to help you answer that question. A lot of times we want to jump to a dashboard. And so it starts with really understanding your processes. And as we all know, implementing an EMR on bad processes just shines a big bright spotlight. Implementing predictive models on bad processes also shines a big spotlight on your bad processes. So you have to have that culture of process improvement first. And as to the previous comments around data and data literacy, then you can start to implement and drive some of the predictive models in advanced analytics.
I appreciate that very much, Dr. Mcgill, and I'm of your exact same religion. I think that as Dr. Vijan said, culture eats strategy for lunch, and I've been covering physician culture for over 30 years, and everything you said resonates with and harmonizes with what I've learned as a journalist in healthcare. So thank you so much, Dr. Mcgill. I really appreciate it. I want to turn to Dr. Skarda now, and the exciting things that you're doing at Intermountain in the perioperative zone. So Dr. Skarda, welcome again. And I love all of these case studies that everyone is presenting here. Tell us a little bit about some of the exciting analytics-driven work that you're doing at Intermountain. Tell us about your role also, please.
Yeah, so that's right. So I am a pediatric surgeon, and I also play an administrative role within Intermountain as the medical director for the Center for Value-Based Surgery. And our journey in value improvement at Intermountain actually started long before I had any role administratively within Intermountain. Nevertheless, over the last 5 to 6 years, we have learned a few important lessons that I think have helped us improve the value of care we deliver. The first lesson is that there is opportunity, and that the opportunity is sometimes dramatically more than we anticipate. Importantly, the way we get value to improve is by having physicians change the way they do things in a way that considers the value of care that they deliver. So historically, and I think most of the panelists will agree, as we went through medical school, we were taught to consider risks and benefits of an intervention or a medication or even a lab test or a diagnostic test of some other type. And what we're trying to do at Intermountain is get physicians to think about risks and benefits and value, and include into that thought process, is this treatment or diagnostic study or medication going to help? And as we do so, what we learned was that data is good, but can be confusing and oftentimes is not as useful as we would like it to be. In particular, in dealing with surgeons who do particular procedures commonly, what we've found is that we need to provide them with relevant data. So for example, we need to provide them data that is grouped into very narrow groups of very similar patients. For example, a general surgeon who removes a lot of gallbladders That surgeon may remove gallbladders in relatively healthy patients in the outpatient setting. They may remove gallbladders in patients in the inpatient setting coming through the ER, and they may remove gallbladders in patients that are very ill coming from the ICU. And it turns out those are three very different patients. And when we show data to clinicians, if we show those groups of patients aggregated together in a big lump, it creates confusion. There are outliers. The initial impression from a lot of clinicians is, hey, my patients are sicker, this, that, the other thing. And once we actually patient group the data in a way that is clinically relevant and show clinicians that data, we begin to gain leverage. And that then allows us to look at preoperative decision-making, intraoperative device utilization, the decision to do the operation or not, and then post-operative interventions such as readmissions, reoperation, infection rate, even mortality rate, which fortunately is extremely rare. And it allows us then to show physicians their data in a very narrow group of patients that allows each of them to compare themselves with other.
And I know that surgeons are like the state of Missouri, right? Show me. They're very data driven. They see themselves as very objective, but as you said, of course, everyone thinks their patients are sicker than everyone else's patients. What has been the experience, and how have the surgeons reacted as you've given them subsequent waves of data, and I'm sure you've sat down with them and explained what you were doing?
Yes. So the initial response is always one of questioning the data. And the simple reality is that the messenger matters, and importantly, the persistence of the messenger matters, in the sense that the messenger has to be able to stand up behind the data and reassure the clinician that the data is relevant, not only to the physician group as a whole, but to them individually. And then once we get past that hurdle and that physician realizes that there is opportunity to improve the care that they deliver, they make changes. Because it is important to remember that physicians, even surgeons, got into this business to actually care for patients and do what's best for them. And they are extraordinarily motivated to do that.
Good. And what have been the biggest lessons learned from your standpoint so far?
Yeah, so I think it's actually patient grouping. And I think that physicians need relevant data that really matters to them. And that is extremely important. And then beyond that, I think an important lesson for me personally is the need to maintain the conversation with clinicians focused on what is best for patients. How do we improve the value of care that we are delivering, which includes outcomes as well as costs, and then persist on that over time.
Yeah, absolutely. Well, thank you so much, Dr. Skarda. So now I'm thrilled. Let's begin a general panel discussion here. If all physicians could show us once again their lovely faces. I would just like to open this up and ask each of you, whoever would like to go first, to react to the other case studies that have been presented. I love the fact that we have 4 accomplished physicians on the same panel. I'm sure you have thoughts. When you hear each other's presentations, how does it strike you in terms of what you're doing with your own analytics? So who would like to be brave and just share a few thoughts first?
Why don't, Mark, I'd be privileged to share a few thoughts. My first thought is it's good to know that I'm not alone. For Dr. Mcgill and Dr. Scarda, the change management principles that they have used, the struggles for the healthcare organization, they're pretty universal. So I appreciate hearing their stories.
That's great. Dr. Scarda, Dr. Mcgill, any thoughts on what you've heard from the other physicians?
You know, I appreciate that there is a need to do this, right? I think all of us are here because in each of our clinical practices dealing with patients, we have witnessed the financial devastation that can occur to patients as a result of the care that we deliver. And those consequences are life-changing and impactful. And you know, it's wonderful from my perspective to see that there are like-minded individuals across the country trying to solve this devastating problem.
Absolutely. Dr. Mcgill, any thoughts?
No, I echo the previous thoughts and comments. I mean, I think that, you know, it's, I always tell people, you know, there's such a small, I mean, it's a growing, but it relatively, compared to healthcare, relatively small group of people that are focusing on this. And so these are not, we can compete on a lot of different things. We can compete on who does the best knee replacement or, you know, open heart surgery or whatever it might be. But let's not compete on the things that really matter to patients, and the outcomes and the quality. And so we should be open with sharing best practices and what's worked and change management principles and challenges as well. And so I think that I echo the comments that have been said so far.
Yeah, absolutely. And I just have to say, first of all, everything that all of you are doing is just amazing. It really is. And, you know, I referenced a moment ago, you know, I've been in healthcare journalism for 32 years, and I've been writing about physicians for that long period of time. And I know it is challenging. It is challenging to make change. I find physicians to be fascinating people because you're all so incredibly bright, incredibly talented, incredibly dedicated, but also sometimes stubborn. And the most interesting thing that I think unites everyone's stories here today, and also most of the stories that we encounter in our reporting, is it all gets involved in the physician culture and the clinician culture, right? Like the only way to create change is to convince people. And I think one of the common threads I see in all of your case studies this morning is that in every case, you've had to sit down with clinicians to, you know, explain what you're doing, right? You've had to explain why you're doing it, what you're doing. You've had to produce data that they can believe, because they'll be the first, as I say, that, you know, and surgeons more than anyone are the show me state people. And it takes a lot to, and one of you said, you know, the messenger is important too. I think when physician leaders share data with other physicians, they are much more likely to be believed than non-clinicians in any case. Dr. Amarasingham, has that been your experience also?
For sure. You know, it was my observation listening to the panel along those comments where it's been exciting to see over the last 10 years. I think there's been also a cultural evolution among clinicians and health systems in terms of embracing these technologies more. I think we talk about the resistance, and I think that's there, but I think more and more physicians that I interact with are saying, look, I love my iPhone. Like, why don't I have a translatable experience in the healthcare environment, right? That, you know, the anticipation that you can get with predictive modeling, the summarization. So to me, there's been a cultural change of less resistance and more, why doesn't it perform at this level of usability and capability in my work? That, you know, that's the first part. And I think the second part that is going to be interesting over the next 5 to 7 years, I think, is moving from pure numerical analysis around all these clinical areas into the kind of summarization and communication that doctors make with one another. Like if I call a pulmonologist that I'm worried about for a patient, I can communicate in one sentence the history of the patient, the current issues, what I'm most worried about. And there's a lot of summarization and prioritization that's going into that. It's multiple different models going into that one statement. And I think we're starting to see AI systems being able to do some of that, which I think is going to help us move from our current state to even more like usability capabilities that I think is going to be really attractive. It's going to get closer to kind of what other industries are doing. So my prediction, my sense is that there's going to be more of an embrace and more requests for this kind of work to make people's lives easier.
Yeah, I think so too, Dr. Marasingham. Doctors Mcgill and Scarda, I'd love to have you respond to both of those things. And I'll formulate two questions. One, I know that you've both told me that once you get a certain number of people converted, as it were, you get some key physicians converted, and then they become evangelists, right? That changes things. So tell me a little bit about how that plays out in physician culture. And then second, what Dr. Marasingham just said, and I agree that the analytics are going to get better and the processes around them will get better so that they will become more embedded in clinical practice. But first, evangelists and kind of turning a few key people. Any thoughts?
Yeah, I think it starts, I think we've taken the approach, we've tried to go with some key influential positions, whether they're leaders or really, I tell you, the people a lot of times that work best are the ones that are your unwritten or hidden leaders, the ones that people listen to, but they're not in a formal leadership position.
Right.
And we've had some great success with one of our one of our general surgeons who's been leading some quality initiatives, not in a formal leadership role, but she has been a great assistant and evangelist. And, I echo the thoughts on the data, the processes, the analytics, the insights. They're only going to get better. They're going to continue to evolve. I think that the next 3, 5, 7, even 10 years are going to be really exciting in healthcare when it comes to data and analytics.
I agree. Dr. Scarda, your thoughts on those two subjects?
Yeah, so in our system, we have 23 facilities, and each individual facility has its own culture and its own set of leaders. And so what we try to do is identify in each facility who the natural leaders are, who are the thought leaders within that facility, and then attempt to make them converts to the process as quickly as possible. Importantly, though, we also show non-anonymous physician comparison data to our physicians. And so it can be a little bit tricky because oftentimes the surgeon at a particular facility who may be the verbal thought leader or maybe the loudest voice may not necessarily be the correct voice. So one of the things that data does is it helps identify at a particular facility which physician actually has the best outcomes. And we can actually show the physicians at that facility what that high quality, high value surgeon is doing so that it's no longer a mystery. Provides those clinicians with insight. And then in terms of the other question, which is, what's the future? Well, I personally think the future is now, right? So some things that we are doing to improve the future or improve the data that we give right now is first and foremost, we're actually collecting data not only from our EMR, but from our billing software, Strata, as well as we are getting information data from our payers, right? So we're not getting information on what's happening in the hospital. We're getting information about what's happening to that patient when they show up to an unaffiliated urgent care or to a competing healthcare system on the other side of town. We actually get all of that information. And then the next thing that we're doing is we are utilizing machine learning and algorithmic based learning processes to help us to identify for these very narrow groups of very similar patients, which events that are in the data are actually related to the focal point of that particular data set. So I was talking about gallbladders earlier. Our data, we pick up when that patient has a gallbladder and then a month and a half later shows up in the ER with a broken arm. We recognize that broken arm is unrelated in terms of the value of that gallbladder. And so what we're doing is using complex machine learning processes to learn and be able to identify related versus unrelated expenses. So once again, when questions come up with clinicians about the validity of the data, we can actually talk to them about how we're trying effectively to remove unrelated events so that their data is relevant.
Wonderful. Dr. Bijan, I'd love you to just comment on what Drs. Skarda and Mcgill shared, if you'd like.
Sure. I echo all their comments and their perspectives on this. And I think data attribution is a really important concept when you're trying to change physician behavior. The validity is important, the relevance is important. If you really want to use this as a tool, you have to break it down into bite-sized pieces. As a general surgeon, I'll take Dr. Skargar's example of a gallbladder. To me, a readmission to the hospital, a readmission to the ER for a patient is only relevant if it was a potential complication related to what I did for them, right? That's what resonates with me, for me to do some introspection to figure out what I could do differently. But if they came back to the ER with a broken arm, I consider that irrelevant. But I think the opportunity for data analysis is identifying patient vulnerabilities for a healthcare system. So while that broken arm may not matter to the surgeon, it matters to the system. So what happened to the patient in between our discharge to that ER readmission with a broken arm? Was there a social vulnerability that led them to fall at home? Are there social determinants of health that we need to tackle and identify? I think health systems who are trying to now improve the healthcare of communities as it translates to quality metrics that matter to us, which is readmissions and complications, is trying to figure out how we can partner with entities in the post-acute care arena, the community benefit organizations, to figure out how we can further help patients beyond our walls. I mean, that is where the future is taking us, because the data is now showing us that, hey, we do a great job of acute inpatient care. We mostly get the patient out with a low infection rate and exceedingly low mortality, but bad things happen when patients leave our walls. And payers, regulators, and now data are showing us that we're going to have to try and impact those patients in the PCP's office, which may be a non-employed physician in a different EMR, in a different area of your service area. So I think we are going to have to use data to reconcile all of those components now. I go back to what CMS talks about, the hospital without walls. And the continuum of care that we provide. That's really the future of where AI analytics are going to take us. And for Dr. Skarda and Dr. Mcgill, myself, for Dr. Amarasingham, our challenge is going to be to bring our physician leaders along with us for this journey.
Absolutely. Beautifully said, Doctor. Well, now we have 3 questions from the audience. So let's get to those so that I can ask each of you to also, at the end, give us a final thought. But let's quickly skip to the questions here. So our first question, sorry, I'm having problems scrolling. Micah asks, which EHR platforms do the panelists utilize to develop and implement models? That's kind of a good basic question. Would people like to share?
Sure. So Parkview, we are a Meditech facility for the inpatient side. We're an eClinicalWorks EMR for the outpatient side. Those are 2 disparate systems that don't communicate well, hence the need for us to engage with Dr. Amarasingham and pieces to be able to do the data analytics as the EMRs are not super sophisticated.
Great. Doctors Mcgill and Skarda?
We're an Epic shop, but we implement some of Epic models, but we also we've been on the Health Catalyst data warehouse for several years, and through our partnership with Microsoft have started to build several models in Azure as well.
Oh, great. And Dr. Scarda?
Yeah, so we are a Cerner system. We also get data from our system, and then we also get data from our payer.
Wonderful, thank you. So we have a comment from Paul Houtman who says, great to see Dr. Marsingham. He set the bar years ago with the paradigm shifting paper on non-physiologic predictors of poor outcomes in heart failure. So that's great. Question for Dr. Marsingham. At what point in the hospitalization is AI applied and data generated to inform the care team? And how stable are the models during the course of hospitalization?
That's a fantastic, very wise question, probably from clearly a practitioner.
Yeah.
So, generally speaking, our view and philosophy of applying AI is that you have to try to mimic as much as possible the clinician thought process, which means that AI has to be applied throughout the patient journey. And we found that, for example, a model on day one, let's say to predict length of stay, is going to be different than on day 17. And that automatically, by being a day 17 patient, means you're a different category altogether, right? From an average length of stay of day 5. So our view is that the models need to be dynamic and be contextualized to a variety of things, including time. The question about stability is an interesting one. A couple different ways to think about stability. Stability could mean consistency of the algorithm in certain cases. And this is a big question FDA is thinking about with AI, which is it like a medical device? Does it perform the same way every time? Very complicated question there. So that there's a lot of work to be done on stability. The second question, though, on stability is the impact it can have on workflow, particularly on clinical issues. So, for example, if a model thought a patient was at high risk, let's say for a deterioration requiring the ICU, and then later, let's say, changed its mind, and so the risk lowered. Physicians do that all the time. But if a model does it, it could set off a chain of activities. And you have to think about how much do you want a model moving up and down, because it can affect big workflows as opposed to how a physician can do it in a nuanced way. So we think about that a lot. We think about what are the upper and lower limits for notification, what kind of stability, because it's going to set off workflows that are more rigid, you need to think about. And what's the context? Is this something that is about surgical failure to rescue or a person going to the unit, or is it about what are the barriers to a discharge? So I think all of those areas require almost artisan-like work in concert with the workflow engineers. So I think the stability question is an excellent question. It's a very nuanced question, and it can be looked at in a lot of different dimensions.
Thank you. So we actually have two more questions. I'll ask them very quickly. I don't necessarily need everyone to respond, but whoever would like, because I still want time for each panelist to give a final thought. One question, I would like to set up a program to determine the effect of wildfires on instances of mesothelioma. And that's the whole question. So I'm not sure what the second part of it is, but does anyone have any thoughts on what the challenges might be in such an analytics program?
I'll start off just being interested in predictive modeling problems, but the first, I think it's a wonderful question, and I'm sure it's coming from someone in the Southwest or West, or actually anywhere these days, I suppose. But the biggest thing is that there's data, right? The first big question is, do you have enough different populations in different subgroups to be able to measure the impact? So there would be clearly a big data question of the number of patients you have in different with both wildfire and not wildfire. What is the kind of type of wildfire? And then mesothelioma, which is exceedingly rare.
Yeah.
So, and then of course you've got time, right? Because the impact of the incident event and then the outcome of the cancer could be, I would assume, not being an expert in mesothelioma, I would assume decades. So this, to me, is the way to do it in terms of setting up a program. This is the reason to have nationalized data on some of these things.
Yeah.
And so it's a great question. I think very difficult one person, but certainly can be, we should be advocating as clinicians for the use of de-identified nationalized data sets to kind of answer these questions.
Absolutely. Thank you. We have a question. I'm just going to read it as it's stated, and then we'll figure it out. Is any ML model have FDA approval for standardized? I think they mean, is there any standardized format? I guess we can kind of interpret what the question says too. Does anyone have any thoughts about that?
Yeah, I think the answer to that question is no. I think that's a machine learning model.
Yeah, yeah.
I'm not aware of there being a FDA-approved machine learning model for anything in healthcare, but I may be wrong about that.
And then they added or minimal criteria for accreditation. I'm not sure that models are going to be accredited.
They're not accredited, but what's interesting in this area, it's rapidly moving. I think the big question for watchers of the field, and there has been kind of early guidance for comment, is will AI systems, of which models kind of component of, ever be considered a medical device? That's how the FDA is looking at it. Because if these AI systems are getting powerful enough where doctors and nurses and others may say, I saw that and I'm going to act on it without reviewing the 1,000 data points to, for example, Dr. Mcgill was saying, who's responsible? And in a device like a pacemaker, if there's a pacemaker malfunction, the manufacturer could be somewhat responsible, right? Depending, will we ever see AI devices with the level of authority that clinicians will be like, I saw it in the AI, I need to move, I have 2 seconds to make this decision, I'm going to go. Then who's responsible? And I think that is very much looking at, will AI ever become a medical device? Now that is it's incredibly fraught question. And it also has implications, I think, for the electronic medical record systems, which have components of this increasingly coming up. So I think it's a question that we're all going to be definitely involved with. And for those that are interested, there are public comment requests from FDA when they put the statements out about the AI and medical device.
Wonderful. Okay, so I wish we had more time. I'm going to give each panelist, and I'm sorry, I apologize, 90 seconds to give us just a brief prediction on how things will look in the next 5 years and their advice for our audience. So again, I apologize, doctors, for limiting you to 90 seconds, but otherwise we'll go over. I'm going to go in alphabetical order from A to Z. So I'll go with you, Dr. Marsingham, first, and then we'll go from there.
What I'm really excited to see, there's going to be tremendous progress. I think what I'm excited to see is that hopefully the joy of medicine will continue to come back rather than the feeling of more automation. I think clinicians, nurses, others will hopefully have more profound and interactive times with patients if this is going the right direction. So that is my prediction that will happen, and I think we'll see some of that with these AI systems more and more replicating the normal communication patterns and other things that physicians and others are expected to see from their own colleagues.
Thank you. Dr. Mcgill.
Yeah, I think we'll see a couple things. I echo what Dr. Marsingham had to say, but I think that we'll see a couple things, having these algorithms be able to take work off of the plate for the clinicians, some of the busy work. I think that will bring some of the joy back. I think 2 other predictions, and they were touched on earlier, really leveraging data and analytics to address some of the social determinants of health, race, and health equity disparities that we see, which is also inherent in some of these models that we need to be able to address, make sure that the models don't have inherent bias in them. And so that's something that's been a hot topic. We could spend a whole hour talking about that. And then the third thing, which is somewhat healthcare is late to the party, I think we'll see a rise over the next, I think COVID really brought this out, is some of the artificial intelligence for non-clinical, non-patient facing activities, things like scheduling, phone trees, referral management, some of those things that are really administrative, really burdensome and fraught with friction for patients. We can have artificial intelligence take some of that work off the plate. So we just shouldn't limit our thinking when it comes to healthcare of just clinical processes. There's a lot of things that occur in healthcare that have nothing to do with the clinical practice of medicine.
Absolutely. Dr. Skarda, thoughts?
Yeah, so the joy of practicing medicine is here and now, and it's only going to get greater. I am personally delighted to be able to get to do what I do. I am convinced that over the next 5 years, the burden that we have all felt over the last decade as we implemented EHRs will produce fruits of assistance to clinicians to provide our patients with better care.
Thank you. And Dr. Vijan?
Yes, this has been a great panel, and I appreciate all your comments. I think history tends to repeat itself. To Dr. Skarda's point of the lessons we've learned from EHR implementation are going to help us navigate the AI journey that is here and now and is inevitably part of the future. I see tools coming to help us make better clinical and non-clinical decisions as care providers. I see tools coming to help with the efficiencies of healthcare delivery. But those tools will only be successful if we as physician leaders get our physician colleagues on board early, be transparent with what we're trying to achieve, how we're going to achieve that, and get back to the why of its importance. And all of those things in change management, they will help us in the future. And we just need to do it in a just, equitable manner with transparency, trust, and kindness, ultimately.
Absolutely. I'm going to cheat for a second here. Someone did ask another question that's really directed at Dr. Vijan. So Dr. Vijan, real briefly, because I want to make a closing statement also, have any models ever been wrong? And how much data do you need to collect in order to predict an outcome? And I know that, one could go on forever, but any super quick thought on that?
So the way our length of stay program works and the way Pieces integrates with us is they give us a benchmark for a certain disease DRG to aim for. And that's based on their proprietary data that they pull from across the country from multiple entities. And so that's the benchmark we look at. And then we look at our patient and say, hey, can we reach or beat that benchmark? And we've been able to do that for a variety of DRGs across the care spectrum. So I think I'm going to have Dr. Amarasinghe comment on how those benchmarks are integrated into Pieces.
Okay, and I apologize, you have a few seconds, Dr. Amarasinghe.
I think the key is just we use those benchmarks against the actual predictive models, and then we can see where is sort of an observed to expected impact. And to the last question, that they had said is how much data you need to predict an outcome. That's really entirely dependent on the outcome itself, how rare it is, and how many patients, similar to the mesothelioma example.
Exactly. Thank you so much. I really appreciate it that you could be so succinct. We are out of time, except I have 1 minute, so I'm going to use the 1 minute. I just want to say, I think, first of all, I tremendously admire everything that all of you are doing in your organizations, tremendously. I think it is the future. It's the way things are going. I also think, for all my references to physician culture, I think that physicians are going to move. I think that their physician practice is changing already, but they're going to move based on data and evidence, and they're going to move based on convincing arguments from their fellow clinicians that make sense to them, right? Everyone wants medical practice to be better. Everyone wants outcomes to be better. And yes, we have to look at this tremendous cost burden. We're, the Medicare actuaries say we're going from the current about 3.6 trillion a year in annual US healthcare expenditures to 6 trillion in the next 5 years, which is completely mind-blowing. And a lot of it is driven by things we can't control, the aging of the population and the explosion in chronic disease. But what you physician leaders are doing is going to point the way to success for the overall healthcare system in the future. You're using data and you're using it convincingly. You're changing physician culture and you're changing practices, and that leads to changing outcomes. So again, Drs. Amarasingam, Mcgill, Skarda, Vijan, I appreciate all of you. I wish you the best as you go forward. And thank you so much for your time, your expertise, and your wisdom this morning. And Matt Rayner is back to thank us and conclude. Thank
Yes,
you.
thank you, Mark. I want to echo what you just said. Thank you, panelists. A great way to kick off our AI virtual day. We are now going to go on a ever so short break. Our next session will be a discussion on AI-powered clinical intelligence, how to reduce the total cost of surgical care. That's going to kick off at 11:30 a.m. Eastern time. So go ahead and stretch those legs, reply to some emails. We'll see you all back here at 11:30. Thank you.
Thank you all. Thank you so much.
Thank you very much. Bye-bye.
Thank you.